Perfect.
My God, my wife is happy because the schedule is working. We kind of catching up. Alejandro is connecting.
Hey, buddies.
Right now, you see. So Curtis, thank you so much. We have the new participant for the competition.
Way to go, buddies. Way to go.
Great marathon. Great marathon.
Thank you. No tengo
Thank you,
cachete
Kurt.
Mexico.
Appreciate it.
Okay, shall I just go with my share screen?
Yes. How are you?
Alejandro, I'm missing a hat for Mexico. That's a really bad thing.
I have mine. Look at this one.
No, let me see who's gonna.
Gators.
I think the closest I'm gonna be Costa Rica.
This is
Pura vida.
This is University of Florida, man.
This is the one,
this
man.
is pura vida. Esto es Costa Rica. I love my costarricenses, you know.
Yeah,
Alejo, that we have a good friend, Esteban.
I just was with a hat like that, but I changed it right now because I said I'm a Gator man and I will present.
That's good.
Thank you.
For this crazy marathon locos.
Oh my God, yeah.
You can say that again.
Yeah, our wife is gonna believe it. They're gonna believe that we're crazy.
Oh,
Look
yeah.
crazy, look at we crazy.
Well, I mean, after looking all of you guys, I mean, it's unbelievable. It's like, what am I going to say? I don't know.
Actually, there isn't anybody that even is going to say anything like yours. So I'm looking forward to this lecture.
Okay, thank you. Okay, we have been listening to everybody since, I mean, like Jeffrey and Dara says, from lips to toes. I mean, it's amazing. But, well, this is me, you know me, and I have no conflicts of interest presenting here, no commercial sponsorships, nothing. And I am in Monterrey, Mexico. Monterrey is northeast. We're close to Texas. And I'm in this building. My clinic is exclusively for oral and maxillofacial surgery. We don't do any other stuff, just those type of bad things. And I am not a Republican. I am not a Democrat. I have enough with my president. But I like this Ronald Reagan sentence. There's no limit to the amount of good you can do if you don't care who gets the credit. And that's what you both are doing, and also the speakers. So thank you very much.
Thank you.
And Frank Dolwick was my mentor in UF, and I've been close now to Villarnet, and I consider to be between these two guys, between the TMJ surgery and between the non-TMJ surgery. So I'm kind of a hybrid now. And of course, you know, my big vaccinator lips rules, Jeffrey, and Dara, and Mike Gonsons, and Bruno from Spain, that I've been learning from them more than in the last 30 years I learned. So it's a revolutionary stuff, this. And also I am taking this from Jeffrey, who showed it last time. And it says that it's a phrase from Steve Jobs. And this is pretty much what is happening right now with us, guys. I mean, we need to connect the dots looking forward, and you only can connect them looking backwards. So you have to trust your dots. And this is something that Steve Jobs said it at Stanford University. I like this, and I think it's a very good phrase, and this is what is happening with us all these days. We are aligning the dots and bringing more things to our knowledge for the good of our patients. So my topic is on minimally TMJ invasive treatment for condylar stabilization. That's the protocol we follow in our clinic. And this is for patients who has dentoskeletal malocclusions. Okay, so I want to focus on this type of patients in the occlusion of people who has dentoskeletal problems, not just regular malocclusion, dental or dentoalveolar malocclusions. And usually we get this type of pathologies, TMJ pathologies, internal derangements and condylar osteoarthrosis. And these are the surgical techniques. I usually do arthrocentesis, sometimes arthroscopy, because the results are very, very similar. And internal arrangements involves dynamic, biochemical, biomechanical, and cellular processes, including disc displacement and deformity of the disc, synovitis and synovial fluid changes, and degenerative articular surface changes, and fibrosis. That's the definition. And we've been taught since the 80s, or maybe early 90s, to follow Wilks classification, which will tell us these 5 categories according if there is clicking, locking, pain, and the MRI imaging or stage. So this is it's a normal disc position, a normal TMJ. And then we can see it in his histology. And in the MRIs, this is the disc here, looks normal. And in the opening also is normal. So this could be a normal one. And then Wilks 1 will say that it's a little displaced, maybe a little noise. And will be Wilks 2 if it is a little bit with a intermittent locking. But this is how they look, a little bit deformed, some effusions. And Wilks 3 and 4 will be more displaced, deformed, and with a locking or painful locking. And in the MRIs, this is the disc displacement, and it gets deformed when the patient wants to translate the condyle, and it's not possible to keep translating. And this is another 4 and 5, until you get very deformed like this, or you get joints degenerations. That is here flattened condyles. So this is what it looks. The point is this: there are 2 opposite points to this. There is different meta-analysis and systematic reviews that says that this displacement made by a single examiner cannot be accepted as a gold standard. And the contours of the disc and its position is not always easily detectable. And also, minus 20 degrees to plus 20 degrees difference in the position, even in the asymptomatic patients. So there is a lack of consent there. And when you see studies like this one from Nitzen that we talk later, the other day, there's no correlation between the severity and the radiographic staging and the pre-op pain, and no correlation between the severity of the radiographic appearance and the response to the treatment. And also patients with closed lock, all of them, they do 100% good after arthrocentesis. And 81% of the patients with arthrocentesis do very good. And then when you see Japanese literature, they do very good with time, even with conservative treatment, non-surgical treatments in the long follow-ups. So in my opinion, Wilks classification needs to be modified. It was really good, it helps a lot, but it's time to do something different. And also in the last decades, it has been said in the literature and in the meetings that the role of this displacement as a primary pathologic factor may not be justified. And also, in view of the new evidence about TMJ internal derangements, treatment should be directed at pain management, reduction of inflammation, decreasing adverse joint loading, and restoration of normal range of motions rather than disc repositioning. So that's why I stay away from disc surgery. And also, studies has demonstrated that osteoarthritic changes in joints were found to have a normal disc-condyle relationship. So such results seems to favor the notion that this displacement is only a sign of the degenerative joint disease, but not the cause. And we are full of literature that when we have compression in the joints, we will have changes in the condyle. And this is in animals, and this is studies done in humans. Every time we compress the condyle, we can get condylar resorptions. And also we know that there is by Arnett, that there is a direct correlations between condylar displacement loading at surgery and late relapse in the mandible and TMJ signs and symptoms. And also another one by Dolwick, that if we put in the operating room as a surgeons, if we place pressure in the condyle, we will get problems. So we need to prevent complications, especially in high-risk joints. And we know that if we do that, as it was described by Gonson and Arnett, we will stimulate the osteoblasts, the cytokines, they will activate the osteoclast, and will destroy the collagen and the HA, the hydroxyapatite. And we know by Nitzen that there will be also free radicals when we do compressions in the joints. And also we need to keep with taking care of the role of the hyaluronic acid to protect the surface of the phospholipids and the process of lubrications. So we need to be taking care of these joints as an integral part of the human body, but not only because it is the disc. And this is a beautiful diagram by Arnett and Gonson that it can tell us that condylar resorption is not only because one thing. So how do we work this type of patients in the clinic? There are different types of protocols: to be conservative and do nothing, or to do surgeries, or total joints, or costochondral grafts, medications, and our protocols. So our protocol is the protocol. And then we use anti-inflammatory non-steroidal drugs, occlusal splints, medications, until the patient is asymptomatic and stable. And then the patient goes for ortho treatment, and then we do the orthodontic surgery. So our protocol goes with medications, arthrocentesis and growth factors. We have to take care of the condylar position during surgery, and a passive hardware or bone plates. So these are the medications we use, the same as Arnett and Gonson. The arthrocentesis, it's our first paper. We did it in '91 with Dolwick and Nitzen, and then we published another one in the British Journal. So we know there is a better mouth opening immediately after the arthrocentesis, reduction of pain, and better function. And the results can be comparable to open surgery or arthroscopy. And these are papers that will tell us that there is evidence that arthrocentesis or arthroscopy will work better than open surgery. And there are meta-analyses and all that. So we just flush the joints. We take out the bad spirits, the cytokines and the Bridgmans and adhesions. Then we place the growth factors. And because we know there is problems with inflammatory cytokines, tumor necrosis factors, deficit with growth factors, MMPs, free radicals, problems with viscosity, synovial membrane is swelled. So that's why we use the growth factors to improve all these areas in the TMJ tissues. And then we can get better results. And there are many studies that will, comparative studies that will tell us that it's doing better than hyaluronic acid, synthetic acid. So then we go for the bivector position. So we like to do short splits in the mandible. We don't do long splints to avoid the muscles space and avoid compression. And we need to take care on how we set the condyle in the fossa. This is for a full lecture, but mainly is we want to keep the condylar movements rotating in condylion, to have passive condylion when you do the movements and avoid torque. So the two words condylar positions will be taking the condyle posterior and superior, pushing it upwards and back, and also giving torque to it, displacing the head of the condyle laterally or medially according to the mandibular movements. And this will be because premature bone contacts. So that's why we have changed in the last 30 years from bicortical screws that will torque the condyle to two bone plates. And the bone plates has to be placed passively. And we keep the patient just with one or two elastic in the anterior part. And for the transverse, for the expansions, we keep this type of palatal stents. So what I'm saying is, it is necessary to do short split, passive bony contacts, bivector condylar setting, passive bone plates fixations, two plates, no bicortical screws and grafts. And if you put the condyle posteriorly, you know you did that, then minimize the bone remodeling with medications. Even if you did torque, you do the same. So this is, as I said, the protocol. These are some patients. This first patient, she came, she has joint pain and locking, and that's her bite. She had already ortho treatment. And you can see there are some condylar flattenings, compressed airway. And when we do first the arthrocentesis, the growth factors, the splint, medications, and that's the patient 3 months later. That's where she is. Her condyle went to a better position, a stable position. Now she can open, she has no pain. We did these studies, sleep studies, and she's with some light sleep apnea, but with a great desaturation, oxygen desaturation. Condyles are kind of flat, but not too much. So we do our prediction tracing. This is how we're gonna move the maxilla and the mandible and open the airway. That's our prediction. And then we're going to the 3D as Dr. Arnett has taught us to do it. We use NemoFab software. And this is the patient. And this is how we're going to advance the patient, how we're going to do the counterclockwise rotation. And this is the patient, 6 months post-op on your right side. And when we superimpose it with the prediction treatment, 3D prediction treatment, there is a very good proximity, precision, and stability. And this is how soft tissues changes also in the upper airway, and we can see how also the hyoid bone tends to go up. This is the difference in the airway. This is the condyles post-ops in the long follow-up. This is the condylar remodeling. We have remodelings, but remodeling is not a pathology. It's remodeling. And this is our patient, initial, pre-op, and final. And finals. So we have a stable occlusion, stable airway, stable muscles, and profile. This is other patient that came with me. She had already ortho treatment, same problem, joint pain. She has intermittent locking. Sometimes she wakes up and she just cannot open it and has pain. She had had different conservative treatments. So she doesn't have too much condylar resorption. She has a good airway. So we did the same. We went for arthrocentesis, spleen, medications. And that's the patient later on. Her muscles are decompensated and now the condyle is in a stable position, free of pain with good range of movements. And that's the airway also. So we did our prediction tracings. How we're going to change the maxilla and the mandible to get a profile, occlusion, and open airway. So we went to the 3D and we take care of the cant and we take care of the midline and the yaw. So this is what we want to do. This is what we did. This is the airway pre and post. We improved the airway. She has stable joints, stable occlusion. This treatment has been done with Invisalign, still not done, still need to set a little bit the posterior part. But she improved the profile and improved the occlusion too. And last case, this is a patient that has same symptoms and she doesn't get a stable malocclusion. And she had already orthodontic surgery. This is she. That's their condyles, which are small, airway reduction. And we can see the condyles, how flat they are. And very small condyles. And this case looks beautiful for TMJ displication or for total joints. The airway reduction, and we did the same protocol. We do the facial evaluations, midlines, cant, and we did the profile. So we do the predictions, how we want to move the case. We do the orientation in the softwares. And here is the movements. Okay, so I have her here, and this is she after. Midlines on, no cant, no yaw. Better profile. Lips they close, relaxed, they're not forced. I learned that from Jeffrey, Lips Rules. Went to New York to follow his course. It's a fantastic course. And that's her occlusion. And that's her airway open. And we can see it on 3D, how it is open and it got improvement. And the joints keep stable. There's no need for a total joint prosthesis, alloplastic prosthesis. There's no need for an open TMJ surgery. Now, how do we know this is stable? Well, this is a study we did on 65 patients. All of them were hyperdivergent, high occlusal planes, and all of them we did 15 millimeters mandibular advancement, more than that. So the requisites for this study was all 65 cases must have more than 15 millimeters advancement at the Pogonian or point B. So we did it with the software. They did calibrations, they recollected data, and we followed them for a year. And I don't want to go through all the study, but these are then they did into the Bonferroni and the ANOVA systems to do these results. So, but I want you to see this. When you see the occlusal plane, the maxillary occlusal plane, from 6 months to 1 year follow-up, there is no relapse. And when you follow the mandibular plane, also is the same, and the overbite and the overjet. These numbers tell us statistically it is significantly, it is stable. So, and then we measure the airway. This past study was accepted for the American Association of Orthodontic to be presented, but was canceled. And this is the other study we did with these cases to measure the airway. And airway opens really good. I want you to see just these last numbers. The airway at the point B and Pogonion, it opens an average of 91, 93%, and maximums of 300%. And when you measure those on 3D, not on a linear AP movements, the airway opens 120 millimeters average, 212%, and maintains stable. So conclusion is, with these protocols on a minimal invasive TMJ procedure, we have long-term stable occlusions, bone morphology, improving mandibular function, and as John Maynard used to say, it is better to be roughly right than precisely wrong. So my personal conclusions are, my patients wants to function. They want to eat these big ribeye pieces. They want to open and chew. So I've been 30 years around the TMJ treatment, and I decided to avoid the spiral of death. No TMJ open surgery.
Wow.
I'm a clinician. I see patients. I don't see MRIs. I treat patients, not MRIs. And it is more important, this mobility, functionability. It's not the disposition, it's the mobility. And it is more important biological solutions than surgical techniques about the suture, the screw, or the prosthesis. And hope to see you September in Monterrey too. In our meeting, we will have lip rules, we will have minimal TMJ surgery, non-TMJ surgery, but the best orthodontic surgery, and also with Julio Cifuentes and Alejandro James in occlusion, and my friends, good ortho people, Mesa and Marcela de la Rosa, Luis Chavez. So thank you very
Esteban
much.
Alvarado from Costa Rica, pura vida.
Thank you so much.
No,
That was
really,
beautiful.
really good. Oh my God, honestly, the beauty of this is, I think mostly holistic dentists, we've always been afraid about maxillofacial surgery. And even that I always want to be a maxillofacial surgeon, when I really get deep into it, I noticed that I consider that the development of technology with all this digital planning increase the precision just so much. I have a patient that I treated in Colombia with Nelson Leon, part of the group as well. But the case where we planned by a maxillofacial surgeon, that he just sent me pictures in articulators, and honestly, I went scared because I was already into the digital arena. And then I say, no way that at this point in life that I'm digital, that I believe in software, I'm gonna even try to do something or support something that I cannot see the final result. And honestly, all the credits to Nemotech and Miguel, because this software is so amazing, honestly.
It is
This
amazing.
software can do everything.
Yes, with everything. And listen, these cases are what I call TMJ garbage patients. In the dental community, they don't want to see them more. They have tried almost everything. So just going easy, conservative, you can have very good, stable results.
This is the case of less is more. We're doing less, you're getting much better results and more functionality for patients. No, it's amazing.
We're waiting for some. Rick is not ready because Rick actually he's doing a webinar that he finished right before a 5. So we're still having some minutes. He's not even finished with the other one.
Yeah,
but good. Then let's try to see if somebody have questions. Otherwise, I will have questions. I always. Alejandro, do you think that everything that we're doing with software, because honestly, we can do everything right now. But sometimes I talk to Dr. Arnett and I say, I know that we can do this and this and this into the software. And he say, yeah, but all this is going to make the surgery more invasive. And that's part of what now I'm going to start going to Venezuela with Nelson Leon to try to see what is the surgical part, to see what we can develop in the software. Because I'm still thinking that people like us, that we stabilize joints in a splint therapy for a long time, and we have the patient right, try to preserve part of that stability,
Yeah,
but it's
the
pretty
point is,
invasive.
yeah, the point is this, Javier. You use the splints, you stabilize the condyles, okay? Once the patient is put to sleep in general anesthesia, forget everything. Everything is gone. Patient is asleep, it's 100% relaxed.
Yeah, but
Now
we
we
still
have,
having gravity in counter working against to us, right?
yeah, so now we have the responsibility to place the condyle in the proper position.
Yeah, but it's still, if we can, that's why digital planning is all about to try to reduce the human error. Nobody make a
Oh,
mistake
yes.
wanting
And
it, right?
up to date, there are surgical guides to cut. You print them 3D, even in titanium.
Mhm.
So plastic has some kind of movement and it's bad. So you print the cutting guides on titanium, and you do the cuts, and you do the pre-holes. You have the guide to do the holes where the future bone plate will be, and you get the personalized custom plates, titanium custom plates. They are bended. The design is for that osteotomy, that patient. And when
That's
you
good.
compare their results, so up to here, technology looks great. But when you go to numbers and you measure the cases and you do the superimpositions to see how precise you are, and you follow them in the long term to see a stability, to see relapse, overbite, overjade, point B, Pagonian, occlusion planes, they have no better results. Why? Because once you open the mandible, you split the mandible and you open it. You have a condyle bare segment and a dental and teeth segment. And if you have premature contacts, it won't help. So you have to keep that feeling. And that's why the best technique to set the condyle is the bivector technique. And guess who developed that technique?
Arnett,
Bill
don't
Arnett.
guess anymore.
Yeah, I mean, so
My God, I'm so sad. Honestly, I asked Dr. Arnett, I say, you need to come, but you know that all the big people now is full of webinars as you are. And but for the next one, I need to have Bill. Honestly, we were talking until the last minute, but he said, "You have pretty much all my people. What you question? What your concerns?" So I bring him part of the half of the speakers of this year Arnett group. They're here sharing with us. That is a totally pleasure. So now people know what we get inspired too much. Alejo, Dr. Sarat is asking if you can put the slide or your contact information back on.
oh, how do I put this slide? I mean, I think share screen again, maybe.
Yeah, share
Yeah.
screen again.
Mhm.
I tested already. No me contesta.
It's here.
No, the one after.
Oh, no, maybe he wants.
No, the one before, the one before.
This one? No. It's, I think will be, it's this one. Could be this one, maybe.
There you go. Yeah.
Good?
Yes, just hold it there for a minute.
Definitely, I can't wait to go to Monterrey.
And
Me voy para tu rancho.
we should do some good big beefs.
Oh my God, yeah. I hear too many stories about that ranch that I definitely need to go. My wife said, "You don't go in alone, okay? You're gonna need to kill 2 cows."
Tell her we'll be nice with you.
Oh my God, that is funny. Okay, let's see. Somebody has more questions. Rick Robles calling me. Hold on, Rick.